Good afternoon. Here is the record of congenital glaucoma. Objectives of the lecture: number 1, to have a knowledge about the signs and symptoms of this type. Number 2, to know how to deal with this type of glaucoma. And number 3, to know whether this type is medical or surgical treated. Primary congenital glaucoma is a rare condition. It affects 1 per 10,000 live births. 65% of the patients are boys, and in 75% of the cases the involvement is bilateral but frequently asymmetrical. The classification of primary congenital glaucoma: number 1, true congenital glaucoma represent 40% of the cases. The IOP becomes elevated during intrauterine life. The second type, infantile glaucoma, represent 55% of the cases and manifested prior to the third birthday. The third type, juvenile glaucoma, which is the least common type, the pressure started to elevate after the third birthday, but before the age of 16 years. The gonioscopy in this type either normal or abnormal. Patients with normal gonioscopy are classed as having juvenile angle glaucoma that behave like adult primary open angle glaucoma. The pathogenesis of primary congenital glaucoma is isolated trabecular dysgenesis, which means there is maldevelopment of the angle of anterior chamber without any other major ocular anomaly. Now the clinical features of primary congenital glaucoma. The clinical features depend on the age of onset and the level of intraocular pressure. But most commonly the features are number 1, corneal haze. The corneal haze often the first sign noticed by the parent, and it caused by this haze, and loss of corneal transparency is caused by corneal epithelial and stromal edema secondary to raised intraocular pressure, and this corneal edema associated with lacrimation, photophobia, and blepharospasm. Number 2, the ophthalmos. Ophthalmos mean there is a large eye. Large eye as a result of stretching of the ocular tissue due to elevated intraocular pressure before the age of 3 years. This enlargement of the eyeball and stretching of ocular tissue, enlargement of the sclera, will give the chance for visualization of the underlying uvea and give the blue color, blue appearance of the eye. As the ocular tissue enlargement continue, the anterior chamber become deeper. There is chance for stretching of the zonule and subluxation of the lens. This enlargement of the eyeball also increase the axial length of the eye and causing axial myopia that give chance to anisotropic amblyopia. Poor visual acuity in patients with congenital glaucoma may be due to anisotropic amblyopia. The third presenting sign was secondary to breaks in descent membrane. This breaks in descent membrane due to corneal stretching will lead to sudden influx of aqueous humor into the corneal stroma. The healed breaks in descent membrane called Hap's striae. The Hap's striae is a horizontal curvilinear lines in the cornea secondary to healed breaks in descent membrane. The fourth presenting sign is here optic disc cupping in infant. The optic disc cupping in patients with primary congenital glaucoma may be secondary to neuronal loss or due to enlargement of the scleral canal. هنا in patient with congenital glaucoma secondary to enlargement of the eyeball. There is enlargement of the scleral canal, and this enlargement of the scleral canal gives chance to enlarge optic nerve cup. So optic cupping in primary congenital glaucoma could be secondary to neuronal loss, enlargement of the scleral canal, or both. In infant, this cupping may regress once IOP is normalized. Here let us present a case of infant about 3 months age, presented by his parent complaining from lacrimation, blepharospasm, and you examine the eye and you notice there is corneal haziness, asymmetrical corneal diameter. Then how you proceed? By examination to confirm whether there is congenital glaucoma or not. Now, asymmetrical corneal diameter or large corneal diameter may be secondary to other causes, but you should first exclude congenital glaucoma. Then you say the condition may be secondary to, for example, megalocornea. You should exclude primary congenital glaucoma in any infant with lacrimation, photophobia, blepharospasm, any infant with hazy cornea. How we proceed and in management to confirm and then to treat the patient. First of all, initial evaluation. The initial evaluation should be performed under general anesthesia. We use intravenous ketamine that give a less chance for reduces IOP, and so as not to get a falsely low intraocular pressure management, we prefer using ketamine. Then we measure intraocular pressure in the theater under general anesthesia by using Perkin tonometer or tonopen to measure the intraocular pressure. Then we measure the corneal diameter. The corneal diameter measured by a caliper, مسطرة خاصة. We measure the vertical and horizontal meridian by the caliper. And if the reading at any age more than 13 millimeter, this is a suspicious reading. But if it is above 14 millimeter, this reading typical of advanced ophthalmos. So we measure intraocular pressure, we measure corneal diameter, we examine the optic disc to see if there is a large cup and measure cup disc ratio. And at the end, finally, we should do gonioscopy by direct gonioscope to visualize the angle of anterior chamber and to recognize the isolated trabecular dysgenesis. The treatment of primary congenital glaucoma is surgical. And the surgery should be done at any age and shouldn't be delayed. The types of surgery may be goniotomy and this can be performed at initial examination when the diagnosis is confirmed, but this is done if there is sufficient corneal clarity and the angle can be visualized. The next type of surgery is a trabeculotomy, and this is done when there is corneal clouding that prevents visualization of the angle, or can be done for failed goniotomy. The third type of surgery is a trabeculectomy and is often successful, especially when it combined with adjuvant antimetabolite. After we treat our patient with congenital glaucoma by surgery, whatever the type of surgery we choose for him, the follow-up should be by intraocular pressure measurement and corneal diameter measurement. Those should be monitored at regular intervals because if there is a progressive enlargement of corneal diameter, this reflects there is uncontrolled congenital glaucoma. and the corneal diameter in children with congenital glaucoma is analogous to progressive field loss in adult type glaucoma. So in primary congenital glaucoma, we can depend on visual field. It's irreliable to be assessed in children, so it's better to follow patient by corneal diameter assessment at regular interval. Now I want to talk about the causes of vision loss in a patient with congenital glaucoma, even those who treated by surgery. The vision loss may be secondary to optic nerve damage, may be secondary to amblyopia, anisometropic amblyopia, secondary to corneal scarring, may be secondary to cataract or lens subluxation. Cycloplegic refraction is important to be done for those child at 6-monthly interval to diagnose and to treat early the anisometropic amblyopia. Differential diagnosis. How we differentiate this serious condition from other, any causes of a cloudy cornea at birth. Cloudy cornea at birth can be secondary to birth trauma, can be secondary to intrauterine infection, for example, intrauterine rubella that give chance for keratitis, or hazy cornea may be secondary to metabolic corneal disorder, hereditary endothelial disorder. These causes of cloudy cornea at birth, and the differentiation for sure by thorough examination, assessment of intraocular pressure, corneal diameter, slit lamp examination to find any signs of keratitis, for example. And the second differential diagnosis for large cornea, for example, how to differentiate the primary congenital glaucoma from any other causes of large corneal diameter. The large cornea may be secondary to megalocornea or secondary to high myopia. In this condition, the cornea large and transparent and intraocular pressure is normal. The third thing that you should differentiate your patient with primary congenital glaucoma from any causes of excessive lacrimation. Excessive lacrimation in infant may be secondary to, for example, simple conjunctivitis or